With regards to breaking bad news, you'll be aware that within the CSA, often there will be a CSA scenario exploring your consultation skills as the nub of the consultation. Usually this is either the angry patient or breaking bad news. Now, with regards to breaking bad news, there are a number of models, whether it's K's or Spike's or Flanagan's, which actually have very similar structure. Now, one of the things Flanagan goes on to talk about is the fact that most of the models are geared to patients in whom there isn't an overwhelming anxiety about the result. And in the CSA, as in real life, what we do know is that sometimes patients can be terribly anxious about the result and what it means for them. And the anxiety can actually very much get in the way of the consultation. So Flanagan does discuss an alternative strategy for dealing with this situation. But let's go back to the common scenario about giving a result which is bad news. It is important, of course, to remember that bad news isn't just cancer. It can be a whole host of things. Anything that adversely affects a person's perception of their future. Colour blindness in somebody who wants to be an electrician, or insulin requiring diabetes in somebody who wants to join the armed forces. So it's always important when you're conveying a result to a patient or a diagnosis to have in the back of your mind as to whether you need to be taking a breaking bad news approach. So with the classical situation whereby the patient may have some anxieties around the result but not enough to get in the way of the consultation, you can use the classical approach. And that's one where you start with the welcome. As always, hi, I'm Dr. Smith, do take a seat, how can I help you today? They'll come out with their opening statement. Oh doc, I've come about the results, that chest x-ray that young trainee doctor organised. Just thought, I got the letter, so I'd better just come and check things out. In that opening statement, it's clear, both verbally and non-verbally, that they're not overly anxious about it, that they're not really anticipating anything sinister or serious. And you can roll with the classical model, which usually focuses on that cue-led approach, reflecting back some of the things they've told you. What did it say in the letter? What did you understand by the test? But usually you're then going to explore what led up to the test, what were they told at the consultation at the time that the test was organised, was anything said at the time of the test, and how they've been doing since the test. Often their ideas, concerns and expectations will come to light. Obviously, if they're expecting a normal result, they won't at that moment in time often have any significant ideas, concerns or expectations. You really then need to find out a little bit about them as a person. It may be perhaps using an approach, we haven't met before, can you just tell me a little bit about you in terms of home, work, hobbies? What you're really doing is exploring his social network and support network that may be available to him once you've broken the bad news, but also starting to get a feel for what the social impact may be, and whether it's going to be something that you may need to address in this consultation. Having done this, the next step is to fire the warning shot, as it's called. This is just about preparing people for the bad news. And Flanagan talks about her shut up, look and listen approach at this point within the consultation. Usually, in terms of fire a warning shot, you're going to be saying something along the lines of, I do have your result. and I'm afraid it's not normal. What Flanagan says is, shut up at this point. Don't talk, just look and listen to what they've got to say. Because until they ask you a question, particularly if they're silent, they're emotionally processing this information that you've given. And over-talking them at this point not only breaks rapport, but looks very doctor-centred. Normally the patient will come back, not normal, doctor. At which point then you've obviously got to break the bad news. I'm afraid your chest x-ray suggests you may have lung cancer. What's important is not to use euphemisms, like, it could be something serious, it could be something nasty. If you suspect cancer, tell them it's cancer. As euphemisms can get in the way of understanding. Just as in the warning shot, Flanagan talks about shut up, look, listen. And it's important that you let the information you've given them sink in. They will come back to you with a question often, are you sure, doctor? And it's at this point that you may actually have to explain why you suspect the diagnosis. And that may include elements of the history, may include elements of examination by other doctors, and of course an explanation of what the result showed. At this time, or at the time of actually breaking the bad news, of course you can get emotion. And it can be a whole range of emotions. Some people may be angry. I told Dr. Smith there was something serious going on. Or it may be relief. Oh, thank God, at least they found something. At least we can move forward now. Or it may just be raw emotion bursting into tears. Whatever the emotion is, you've just got to let them ventilate. Show some genuine empathy. I'm very sorry to have to give you this bad news, or I can see that this is very upsetting, and I'm sorry to give you the news. It is much better to sound really genuine and mean it once than simple wooden repetition of I'm sorry. Then the next step is actually explaining what's going to happen next. Because if people understand the diagnosis in terms of what it means, why it's caused the symptoms they have, and if your explanation intuitively makes sense of the investigations or managements that are going to follow, and then you start to work up a medical management plan, this will help allay anxiety, as it's through understanding that you reduce anxiety. In terms of the planning, there may be no options really to share with regards to medicine. They may just need a 2-week wait. The process of the 2-week system, explaining what will happen when they see the specialist. But it's important to realise that you may, of course, need to think outside of medicine in terms of, do they need a fit note, altered duties, or time off work? Do they need a patient information leaflet explained in a way, the contents that is, that makes sense and gives value to the leaflet, to the patient? You may be offering them an opportunity to come with a partner or a friend within a day or two to answer some of the questions that will naturally have been generated once they've left your consultation room. So, with regards to the plan, having explained it, having mutually agreed elements of it, then it's important to summarise. You've just given them shattering information. They're only going to remember some of what you've told them. and therefore it's very important to summarise the key bits. Make sure you've safety netted around any referrals and to give them a specific time for review. In some situations this may literally be the next day after seeing you. In others it may be after they've had the 2-week wait, where you may be translating the information that they were provided in a secondary care setting into a way they can better understand. Now, we talked earlier, right at the beginning, about the situation where the patient is overwhelmed with anxiety about the result. And they'll come in, again, you've got your welcome, but their opening statement will be seeded with cues. I've come for the result, doctor. I got the letter. I haven't slept a wink since. It sounds really, really worrying, doctor. And clearly you've got a real feeling that this is somebody who is terribly anxious about the result. Now, if you take the classical approach about finding out what led up to the test, you know, what the doctor said, what happened at the time of the test, what's happened since, they're going to be on tenterhooks throughout this. They are going to be really engaging in your questioning and questions and answers. It will seem very doctor-centred. There will be no rapport. So you do have to take a different approach. Of course, you can, when they've opened their opening statement, use some of the information within that to get a flavour or confirmation of their anxiety. He mentions that it kept you awake all night. Leave it hanging. And again, they'll represent their overwhelming anxiety. It's at this point that you've actually got to say, okay, I've got to be flexible with my structure. And you might say something along the lines of, well, normally, because we haven't met before, I'd be finding out about what led up to the test, what they said at the test, how have you been since. But I just get the feeling you're desperately worried and you just want me to give you the result right now. Is that right? At which point they'll usually say yes. And then you're going to launch in, as in the classical model, that is to say, with your warning shot, and then shut up, look, listen. Breaking the bad news, shut up, look, listen. Show empathy, allowing emotion, explaining why you think they've got the condition, and focusing on the medical elements of what happens next. But then, of course, you're going to go back to actually having to explore their support network. Now, we've talked about how we're going to help sort out what's exactly going on. But I haven't met you before, and it'd be really useful for me to know a little bit more about you as a person in terms of who's at home, you know, work, hobbies. Because that will then influence the non-medical elements of your management plan. Again, you're going to bring it all together with a summary and a specific review with appropriate safety netting.